Hello, everybody. It is my pleasure to be here with you in the ninth annual conference of Andhra Pradesh Obstetric and Gynecology Society. I wish I was here physically to meet all of you, but this time I'm going to do it through recording due to other commitments. So, to start with, I would like to introduce a little bit about myself. I'm currently the president of the American Board of Cosmetic Gynecology, established in 2018 here in New Jersey, United States, as well as the president of the American Aesthetic Association since 2016. I am a cosmetic surgeon, not a gynecologist, but I had a special interest in the field of cosmetic, regenerative, and functional gynecology for the longest time. And here in this lecture, I'm going to share with you my thoughts about why in this era there is a new emergent specialty of functional, regenerative, and cosmetic gynecology that all of you should be involved in. I have few disclosures to mention. None of it will be interfering with my presentation for this time. So the first fact is that the world have 8 billion people, 5.6 billion women. Amongst those, today in 2024, there is 1.1 billion menopausal women. And this number continue to increase by 20% every year because of the baby boomer population. A number that is really, really impressive due to the lack of trained doctors who can deal with their own problems. So the problems that happens after menopause are multi level. The first problem that we deal with is vulvovaginal atrophy. And vulvovaginal atrophy affects 50% of postmenopausal women, 25% under hormone replacement therapy already. Even 15% of premenopausal women can have this issue. Again, 50 to 70% of breast cancer survivors have one or more of these symptoms of vulvovaginal atrophy, and most women do not know that is a chronic progressive worsening condition. The problem is that most of us as doctors don't have the time or the training to open a discussion concerning these issues. And the end point is that 77% of women affected with vulvovaginal atrophy will avoid intercourse with their partners, which have severe negative implications on interpersonal relationships, marital discord, and eventual divorce. So let's talk about the pathogenesis of vulvovaginal atrophy. In the skin, as well as the mucous membranes, we have the first layer, which is an opaque avascular layer hiding the color of the blood in our dermis or lamina propria, made of about 70 micron of 5 layers of cells, starting from the stratum basale or germinativum. With mitosis, it will divide into stratum spongiosum. Stratum spongiosum will accumulate granules called the lipofuscin granules, causing the stratum to become more opaque, what we call stratum granulosum. And then stratum granulosum will have much more density of these granules, and we call it stratum lucidum, which is completely opaque. Lucidum in Latin means opaque. And this will eventually become a stratum corneum in keratinized stratified squamous epithelium, like the skin or the labia minora, until the heart's line. In the mucous membrane, we don't have the keratinized layer. With progression of time, this dermal, epidermal junction, which you can see here as reeds to increase the surface area, will kind of flatten and becomes a much less wavy. And this reduces the absorption surface of the nutrients from the very vascular dermis or lamina propria into the overlaying epidermis. And this results in atrophy of the 70 micron layer down to very few microns. Hence, you can see that you have loss of Rouget in the vaginal epithelium. You can actually see vessels visually in the lamina propria. And what end up happening is that patients who try to have intercourse will have cracking, fissuring, and this will end up causing dyspareunia. This is a picture that I always like to show in my lectures, showing the significance, the historical significance of functional gynecology as it evolves in this era. We all know that liposuction is the most commonly performed cosmetic procedure on the planet. Liposuction was actually invented by two gynecologists, a father and a son, Giorgio and Arbat Fischer in Rome in 1973. Two French plastic surgeons, Pierre Fournier, who's seen here in this picture in Singapore in 2015, celebrating his 90th birthday, which I had the honor to attend, have traveled to Rome and help Giorgio and Arbat Fischer to evolve this procedure, improve the technique, use hollow cannulas, use negative suction to settle down this new surgical procedure for fat reduction. The first case of liposuction performed here in the United States was performed in 1984 by an internal surgeon. His name is Newman. And what I'm saying is that it took 11 years from the invention of the procedure in Rome until the first case was performed in the United States. This 11-year gap on a procedure that pretty much every single person on the planet could be a candidate. Doctors knew about the procedure, but didn't know where to go for training. Patients in 1980s did not have the advantage of social media that we have now extensively that teaches our clients and our patients about the new advances in medicine. But yet a lot of them heard of it but didn't know where to go. The status of cosmetic gynecology or functional regenerative gynecology in 2024 pretty much is the same status of liposuction in 1984. All our female patients are candidates. Very few gynecologists are trained appropriately to deal with these issues affecting the function of the female genital system. But patients are fully aware of this subspecialty, helping them to deal with their problems, whether it is an O-shot, whether it's a labiaplasty, whether it's energy-based devices, whether it's hormone replacement therapy, and so forth. So this is our moral duty to propagate this new subspecialty and make it a stand-alone subspecialty in the field of gynecology with a huge impact on people's lives and longevity. The definition of health by the World Health Organization is complete physical, mental, and social well-being, not merely the absence of disease or infirmity. And this is exactly what that specialty is serving patients right now. So another issue is the vaginal relaxation syndrome, which all of you should be aware of. Vaginal relaxation syndrome is described because since 2012, because of the nature of this birth canal. The vagina develops from two embryological components, the urogenital sinus, which is an insensitive endoderm that descends from north to south, and the genital tubercle, which is a sensitive ectoderm that goes upwards from south to north, and they are meeting at the level of the hymen. So the function of the hymen is literally an anatomical landmark that delineates the junction of the upper two-third insensitive part and the lower one-third or orgasmic plateau very sensitive part. And as you know, in many cultures, the hymen constitutes some moral value. In certain countries, women have to be virgin at the time of marriage, and hence the procedure of hymenoplasty. But it doesn't serve actually any function. When the woman is nulliparous, this tube is very tight, and usually the husband is still young, have very high or optimal levels of free testosterone, and that give good erection and ability for mechanical contact between the penetrating penis and the tight vaginal tube. With passage of time, with multitude of normal vaginal deliveries, with relaxin hormone and with trauma from the birth, causing disruption of the collagen bundles and possibly some tearing or some episiotomy performed and so forth. What happens to this tube? It becomes more batulous and more widened. And this reduces the chance of mechanical contact during coitus, especially after passage of decades. And now the husband is afflicted with hypertension that causes 8.5% chance for impotence or erectile dysfunction, taking diabetes into action that reduces the ability to have an erection and so forth. So the process of aging as well naturally will cause a reduction in the precursors of collagen named transforming growth factor alpha and beta, as well as it disrupts the action improperly inducing metalloproteinase that is designed to remodel our wounds, but yet in this case it will destroy the normal elastin or type 3 collagen responsible for elasticity. So altogether will result in vaginal relaxation syndrome. So what is cosmetic gynecology or functional gynecology and regenerative gynecology? It's simply a new, exciting, demanding, and progressively expanding new subspecialty in the field of gynecology. It is an exponential increase of the number of patients requesting those procedures from the knowledge by social media, faced at the same time with very limited number of trained physicians to perform these services worldwide. It is currently the fastest growing subspecialty in all subspecialties of medicine, which deal with aesthetic and functional enhancement of female genitalia, whether it's the minora, the majora, the hood, the clitoris, the vagina, perineum, and mons veneris. Cosmetic gynecology procedures have been popularized in the media and often reflect the insecurities of some women have about their body's genitalia and the fantasies of their male partners. As you see, this specialty is exploding worldwide. We have given hundreds of lectures, courses, and symposia worldwide in all these countries about this emerging subspecialties in the past 10 years. And we have to understand that the uh, uh, variation of the morphology of the external genitalia is all normal. Our colleague and friend from London, who is a sculptor, Jim McCarthy, who was visiting my practice in Manhattan recently, have made 400 plaster casts of 400 volunteer women, and to show that the introitus of a woman is absolutely normal with all its variations depending on their barcode or genetic material. Only it is abnormal when it's causing some form of functional or aesthetic complaint with the patient. Functional, like inability to wear certain things or use a bicycle or ride on a horse or chafing or irritation, or if it is aesthetic, causing patients to be self-aware of their abnormal look of protruded labia and so forth. But otherwise, if the patients are not complaining of such a problem, we consider this a normal variation. Again, like I said, in a study by Koenig in 482 patients, it was found that 14% only of the patients thought that the labia minora looked abnormal. while 78% of women found that the labia minora reduction was necessary because of the impact or the influence from social media they are following. This is a study by my colleague, Dr. Michael Goodman, in 2012 published this paper, and it is very impressive to see that the patient satisfaction overall is 90 to 95% range, and the sexual satisfaction is 80 to 85% range, which I find very impressive compared to other similar aesthetic procedures in the rest of the human body, where the satisfaction usually is much less figure. So we have a lot of tools that is continuously evolving day after day to improve the functionality of the female genital tract. We have injectables, including exosomes, including platelet-rich plasma, growth factor serum, hyaluronic acid fillers, botulinum toxin with all its applications in gynecology, as well as carboxy therapy injecting carbon dioxide gas. Uh, so the other issues are using topicals, including topical hyaluronic acid in the vagina, which allow hygroscopic effect on improving moisture for 3 days. The use of mesotherapy for fat reduction in the mons veneris and improving the outlook of the introitus, as well as using chemical peels like lactic and mandelic acid for genital lightening and bleaching. Again, we have several energy-based devices, including lasers, and currently we have three different types of lasers. We have 1470 diode lasers. We have erbium 2940 nanometer non-ablative erbium laser, and we have carbon dioxide 10,600 nanometer that is used as an ablative fractional method to tighten the vagina. We have as well radio frequency that was FDA approved in the United States in 2015 by my colleague and friend, Dr. Red Alensod, the device called Thermiva. Now we have multitude of devices that is used either unipolar or bipolar. And the unipolar, where you have to have the anode in your hand and the electric current goes through the entire thickness of the body of the patient, and the cathode is attached in the buttocks region as a grounding pad. While the bipolar, when you have two rings and the electric current will run half the distance between the two rings or electrodes. Now we have as well the high intensity focused ultrasound, which is very effective and safe method of tightening vaginal relaxation syndrome. We all use ultrasound to determine the sex of the infant. But if we use a focusing lens at the focal length of 3 millimeters, now we are creating a small, minute microscopic burns in the lamina propria at a level of 3 millimeters, which is pretty much the depth of the lamina propria slash muscularis mucosa of the vagina, as well as another focusing lens at the level of 4.5 millimeter, which reach all the way through transmurally to the periphery of the vaginal wall where the adventitia is. It is very efficient and effective in patients who have moderate form of cystocele and rectocele, and it's performed as 1 to 2 sessions every year and need maintenance therapy yearly, of course, like all energy-based devices. The other energy-based device that we use as well is low-level light therapy or LED, light emitting diodes with three colors. The red color in 694 nanometer range is used for vaginal atrophy, for vulvovaginal atrophy, improving moisture, improving vaginal mucosa, The green is used for dyschromias and vaginal dysmorphic syndrome caused by the hyperpigmentation, while the blue device is used for infection. So patients with recurrent bacterial vaginosis, recurrent uh, uh, yeast infection can benefit from the use of blue LED therapy. We usually apply this for 8 times, twice a week for 4 weeks. Then the last or the fifth device of energy-based device is the plasmage. And plasmage or a plasma pen or plexer uses electric current to ionize the nitrogen in the atmosphere, and this create a mini spark. And that spark, when applied to the external genitalia, whether this is the hood, the labia majora, or the labia minora, will result in a very minute microscopic injury that will heal within 7 to 10 days, causing contracture, coagulation, and reduction in the dimension of the structure. So again, this is the example of the first radio frequency device approved in United States, which is Termiva by my friend Red Allen Sod. And as you see here, it has an anode that looks like a little a toothbrush and have grading of in centimeter to know how deep we are. And then the device can be set to a maximal temperature. The maximal temperature that we use for radio frequency is 42 degrees Celsius surface temperature. And at this point, when we reach the 42 degrees Celsius, then the device shuts itself off to avoid overheating. Because when the temperature of the mucosa is reaching 42 degrees Celsius, that means the temperature of the lamina propria is 60 to 65 degrees Celsius. The ultimate degree for fibroblast new collagenesis is 63 degrees. Uh, Again, there is high patient level of satisfaction up to 80%. Photona laser publication have showed shrinkage of the vaginal lumen by 17%. The use of photona in contyulase, urethral have shown that patient incontinence after 120 days or 4 months was up to 60%, and they remain dry 68% of the patient after 1 year. The all energy-based devices require an initial sessions that is different from every energy-based device, like I'm going to explain, but needs maintenance yearly depending on the patient, because we have something called the collagen remodeling capacity. And the collagen remodeling capacity, or the ability to produce collagen, varies between individuals. So when it comes to lasers, as I mentioned, we have two major contenders. The carbon dioxide laser that causes 82 microthermal zone injury. And in between of them, there is usually intact mucosa. And when we apply these lasers, two things have to be mentioned. First, the above the hymen, we use higher joules, like 90 joules, for example. Below the hymen, where it's a sensitive area, we have to use a topical anesthetic cream to avoid discomfort to the patient, like BLT or benzathine, 20%, lidocaine, 8%, tetracaine, 8%. Usually, we apply 3 passes of this laser, and patients should not be having coitus for 1 week because of the presence of these thermal injuries. When you see the injuries in the mucosa, it is made of 3 zones. The central core of the injury of carbon dioxide, the temperature reaches above 100 degrees Celsius and less vaporization. The second zone is 100 to 80 degrees, and this leads to coagulation or shrinkage of the vaginal tube. The same thing like if you're buying a meat steak and you put it on heat or grill, you'll find that the steak shrink in its dimensions. While the outermost zone temperature ranges between 80 and 60, And in this case, you have zone of stimulation or formation of new collagen by stimulating the fibroblasts in the lamina propria. The second type of laser, which is non-ablative, is using erbium gas, emitting equivalent of 2,940. If we apply this laser in the ablative form, let's say on the introitus for dyschromias or just removing the fine lines or the pore size reduction, in this case, the pulse duration is very short. It's like 30 milliseconds. But in case of the vagina, we do not really need to ablate the mucosa or remove the mucosa. So all what we do is to increase the pulse duration from 30 millisecond 10 times to 300 millisecond. And in this case, a laser will heat this vaginal wall evenly and diffusely, and this will lead to contracture and tightening, reduction probably by 17% as published in the data. Again, we're going to talk about the HIFU. The HIFU use the high intensity focus ultrasound waves through a special probe. These cartridges are either 3 millimeter deep firing or 4.5 millimeter deep firing. We usually perform 1 to 2 treatments for those patients selectively having some degree of organ prolapse like cystocele or rectocele, and they usually require one maintenance treatment yearly. Comes to the high intensity focus electromagnetic waves or the chair. There's different chairs in the market, all based on using the electromagnetic power, and patients usually sit on it without any need to remove their clothes. And as you see here, patients will have 11,800 kegels per maximal contraction in 28 minutes. And if you look at the ultrasound evidence of pelvic floor muscle contraction and elevation, it is very, very impressive. Remember, older menopausal women have an issue with sarcopenia, and it is very difficult for a menopausal woman to perform Kegel 11,800 maximal contractions on her own. So the regimen for the Emsella or the HIFM chairs in general is 6 sessions. We do it twice a week for 3 consecutive weeks. It was found to be very useful for stress urinary incontinence, pelvic floor muscle remodeling, as well as used in men for erectile dysfunctions. It improves the control of the pelvic muscles during erection. Again, there is vaginal and labial tightening. There is urinary incontinence correction. There is a vulvar bleaching. And in the bleaching, I'm going to talk about it in particular because of the Indian population, Asian population, Middle Eastern population, Hispanic population, and American Indian population, according to Lancer ethnicity scale described in 1998, are skin type 4 by Fitzpatrick classification. And in these 4 races, if patient have any kind of form of trauma, whether this is a thermal trauma from a laser, resurfacing, or a burn, or it's a chemical trauma from an acid of a chemical peel, what ends up happening that the skin melanocytes will produce more melanosomes eventually and cause more dyschromia. So those patients, especially in India, before you do any kind of laser resurfacing or you peel them with lactic or mandelic acid 30, 40, 50%, you have to make sure that you prepare them for 4 weeks using Kligman formula. Kligman formula consists of 3 products, 6% hydroquinone, 0.025% retinoic acid, and 1% hydrocortisone. Retinoic acid helps to penetration of hydroquinone into the skin cells. It induces new collagenesis. It disperses the already present melanosomes causing the dyschromia in the genital area. While hydroquinone is a reversible cytotoxic agent for the melanocytes, it inhibits tyrosinase enzyme that are responsible for formation of melanin from tyrosine through dopaquinone, and dopaquinone would eventually make the pigment or the eumelanin through a process under the influence of melanocortin stimulating hormone by combination with 3-cyclic AMPs. Uh, Again, regenerative gynecology involved many new trends, including platelet-rich plasma, growth factor, and again, the FDA is in the field in the process of studying all the proposals for using stem cells. But as we know, we have uh, stem cells in our body. We have 10,000 stem cells in the peripheral blood, 50,000 stem cells per cubic cc in our red bone marrow, and the richest in stem cell source would be our fat. Adipose-derived stem cells can constitute up to 5 to 10 million stem cells per cubic cc, and the use of nano fat and microfat in genital rejuvenation is a field that has to be explored and studied more and have more evidence-based medicine. Again, the field of bioidentical hormone replacement therapy is a huge field with people who are specifically specialized to deal with this. The use of vaginal threads have been controversial. There is some people who are using it for tightening. There is some people who are using absorbable threads for just new collagenesis, but it is something that some doctors have an interest to learn. When it comes to the injectables, platelet-rich plasma contain about 300 plus growth factors. And when we use the puffy coat, which is the lower portion after spinning in an FDA-approved system consisting of 1 million platelets as well as the WBCs or the white blood cells, it contains transforming growth factors alpha and beta. It contains angiogenic growth factors that helps with the production of collagen, as well as platelet-rich plasma will awaken our mature stem cells into differentiating into progenitor pluripotent cells that makes new tissues. Platelet-rich plasma as well does something called homing, means that it directs your immune system to the area of issue. Use of botulinum toxin is in gynecology have been expanding. Botulinum toxin is one of the most heavily studied drugs and have so many therapeutic applications. I use it mainly for treatment of vaginismus. Vaginismus have 4 grades. Grade 1, when there is a little discomfort. Grade 2, when there is significant pain, but during examination, patient will not lift their buttocks off the table to guard themselves. Grade 3, when there is actual pain and crying and screaming. And those patients, when you examine them, they will lift their buttocks off the table. While grade 4 is impossible penetration, non-consummation of marriage. People can be married for years and the lady or the wife is still virgin. So in grade 4, we have to put the patient down in order to treat them. Grade 1, 2, and 3, we can treat them awake. I use 50 units of Botox in grade 1, 100 units in grade 2, 150 in grade 3. And we divide these units at 3 points, 2 o'clock, 3 o'clock, 4 o'clock on the patient left side, 9 o'clock, 10 o'clock, 8 o'clock on the patient right side in the litotic position, 1 centimeter above the hymen. And we do not need to numb the patient because this is an insensitive area. Remember, the muscle or puba vaginalis muscle, which is the most significant muscle in vaginismus, as by 2 studies by Van de Wiel and Lamont in 1990 and 1994, determined that the pubovaginalis or bulbo cavernosus muscle is the most important muscle in this problem. So for treating vaginismus is one application. The second application for botulinum toxin is overactive bladder by injecting into the detritus muscle in the base of the bladder. The third application of botulinum toxin is used for orgasmic dysfunction by injection of 5 units of botulinum toxin in each corpus cavernosum of the clitoris. And the whole concept of that is to relax the smooth muscles sitting in the corpus cavernosum of the clitoris, allowing more easier engorgement and distension of the corpus cavernosum during coitus. Application of carboxytherapy is simple, based on the Bohr's effect. Bohr's effect is what we make to oxygenate our blood from venous blood coming to the lungs into oxygenated blood by the red blood cells in the arterial side, because there is a high pH in the alveoli, hence there is a good attachment of the 4 oxygens attached to the 1 red blood cells. While when we go to the capillary end of the circulation, there is a metabolic acidosis, and this low pH move the carbon association curve to the left, and that releases the oxygen in the tissues. So we inject simply carbon dioxide in the tissues with very small needle. It could be in the suprapubic region. It could be in the orgasmic plateau or lower third of the vagina. It could be over the labia majora. And what ends up happening, formation of carbonic acid will reduce the pH, releasing oxygen, induce vasodilatation and endothelial growth factors, as well as the carbon dioxide gas is very safe to use due to the fact that it is 25 times more soluble than oxygen in the blood. So the chance for gas embolization is almost nil. Again, I mentioned the value of adipose-derived stem cells in gynecology. Fat is made of different component cells. For every syringe of fat that we use, only 20 to 30% of the cellular count is made of adipocytes, which ranges in the range of about 130 microns. But 40% of the cellular count in this is made of adipose-derived stem cells, which can differentiate into different kinds of lineage of the human cells to replenish the damaged or lost cells that we need. Again, we use hyaluronic acid for 4 different applications. We can use the non-cross-linked hyaluronic acid for its hygroscopic effect. Hyaluronic acid can absorb each gram 6 liters of water around it, and it can absorb 1,000 times its molecular weight of water. So we can use it for rejuvenation of the labia majora, reinflation of the labia majora. We can use it if we use the high cross-link that stays for about 6 to 8 months for a clitoral lifting by injecting 0.2 cc's under the clitoris glands at 6 p.m. As well as we can duplicate what our colleague David Matlock in 2002 patented as G-spot amplification by injecting 1 cc of hyaluronic acid in the lamina propria, 1.65 centimeter cephalic of the urethral meatus, 35 degrees to the left. We have good improvement of the functional sexual improvement up to 91.2% in females, and with their male partners using assessment questionnaire and enhanced quality of life is 82%. Finally, I just have to go over 5 quick challenges that you have to keep in mind going into that new subspecialty. The first one is the evidence-based medicine, and this is already have been solved because currently we have 800 publications on PRP in gynecology, 90 of them specifically in cosmetic gynecology. We have publications on 700 plus cases of erbium non-ablative laser, and we have much more bigger series documenting the all different applications in cosmetic gynecology that is supporting all these efforts in this new emerging subspecialty. The second is the timid patients. I know Indian patients are kind of shy, and we can go around this by giving patients translated forms like Arizona Sexual Excitement Scale form, Female Sexual Index Scale forms, and they fill it out at the upon entering the office, and you can look at these forms and assess their sexual issues without asking silly questions or embarrassing questions. Training, and that's why I highly recommend for you to attend a formal training with some legitimate, well-reviewed trainer, and I'm sure you have a lot of very well qualified cosmetic gynecologists in India. So as I come here often, and my pleasure to meet you and help you to get on that subspecialty by training through our American Aesthetic Association fellowship program for 4 days, including surgical and non-surgical options. Finally, the beauty is in the eye of the beholder. When you reconstruct introitus, you might say it is horrible and the patient loves it, and vice versa. So actually, the best thing to do is to select your patients appropriately. Patients who have lower expectations and have significant deformity that you can, with your expertise, fix it. But you don't want to get a patient who have very little deformity with very high expectation. This is calling a problem upon yourself. So just be very selective in choosing the patients. And in certain countries, like where I came from, I'm Egyptian by birth, the incidence of female genital mutilation is 89%. So as in Mali, in Sudan, in Chad, in Ethiopia, many other countries, and with immigration, even in the United States, we still see these cases. And the problem is the World Health Organization still defines all procedures involving partial or total removal of external female genitalia, whether for cultural, religious, or non-therapeutic reasons, is female genital mutilation. We've been working with the WHO to re-modify this term, because the difference between doing such a crime for which the world have already put an international day to have zero tolerance for that of February 6th, is that patients don't have consent to do that, and usually results are catastrophic. While cosmetic gynecology procedure is done with the patient consent, and they wanted to do that for functional or aesthetic purposes. So we do not do that. We do not do that, which is type 2 and type 3 or infibulation. So why should you learn cosmetic gynecology? It is the future subspecialty. Many candidates, all women are candidates, huge demand in the market. There is no official residency training program until now. Patients are aware of those treatments through social media. Very high patient satisfaction, which is very, very good for the doctor to feel that he did something good for the patient. You have to learn how to be a plastic surgeon or plastic gynecologist by meticulous surgical techniques or fingers of a lady. Because if you take care of the wound will take care of you. Artistic visionary surgeon, years of training and practice, good patient selection, choices and realistic expectations for your patients, individual assessment, and medical code of ethics. Thank you very much. I wish I was there personally. Hopefully, I'll meet you guys there in India very soon. This is my Instagram, Ayman El Attar MD. Please follow me, and best wishes, and hopefully we'll meet each other very soon in India. Thank you very much.